Okay, so welcome everyone to this evening's Lambeth Southwark Lewisham training session. We've got Simon Browning with us again. Thank you very much for taking this session for us. Over to you.
Thank you very much once again, and good evening to you all, everybody. I thank you all. I'm well aware that down in London tonight, a couple of teams, namely Tottenham and Chelsea, are playing each other, and Premiership could be dependent upon it. So, thank you for prioritising me over that match. I'm very honoured. Uh, Tonight, to me, is always a very exciting lecture. This is about holes, tears, retinal detachments, the big bogey ones that could have major effects on people's vision very, very quickly. And I think when it comes to ultra wide field imaging, one of the things people worry about as much as anything, because they begin to see things they never used to see before. Now, hopefully by now, with these lectures, you've begun to see that ultra wide field imaging is such an important part of practice nowadays in many places, and you can begin to see the power of it. And hopefully tonight's lecture will bring that into us as well. Just a quick thing. Since last month, you'll remember we talked quite a few things last month, and I couldn't stop receiving throughout the last month, details about myopia and the effects of myopia on the retina. And I think one of the most interesting things I received was the Eyes on Eye Care report from America, and the the results of the questionnaire that went out to optometrists there. And one of the questions was, should axial length be monitored in myopic patients routinely in every patient? And the result was nearly 71% of optometrists said this is an absolute vital measurement if you are dealing with myopic patients. So I thought it was quite an interesting result to suddenly back up what we decided last time. And of course, the other thing that came to light in the last month since the lecture, the uprising of Ebola again in DRC. So it just goes to show these diseases are always with us, and they're always relevant in lectures, no matter how obscure they might be. So yeah, it's nice to be on the cutting edge. I've gone through tonight's lecture to make sure there's no strange diseases there that we could fire up again. So hopefully we'll be okay. So ultra wide field imaging, holes, tears, and retinal detachments. Many people still consider the slit lamp and the contact or non-contact lens exam is the sort of, with scleral depression, is the gold standard when you start looking for tears and detachments in the periphery of a retina. And historically that's the case, and it may still be the case if you're in a specialist clinic, but obviously in a routine high street setting, it's very time consuming, it's invasive, and it can have an effect on the patient, like preventing them driving and things like that when we've dilated the patient. And it really needs good specialist approach to it, and you really need to be doing this very, very regularly. And I mean, I've yet to meet an optometrist recently who regularly, if ever, does scleral indentation on a patient nowadays. So yeah, in reality, that sort of gold standard care doesn't happen in a high street setting. But we know our patients, when they walk through the front door, want to know that everything is fine and well with them. So we've got to do our very best for them. So the benefits of ultra wide field imaging, as we've discussed before, it's fast, it's non-invasive, and we know from the copious number of research papers that come out just how many more lesions we have an ability to see there. And this is a benefit to the patient. Some people worry that it will unnecessarily worry the patient, but that's really down to how we communicate with the patient. But what it means to the patient is, if we find these sorts of lesions early on, then we can monitor them, or if they need treatment, we can treat them. And that treatment is so much more straightforward, and the outcomes are so much better at an early stage. And the outcomes, the ongoing sort of results, are far better for the patient. And many, many times we can get there before the horse has bolted. We stop serious sight-threatening pathology. And of course, from outside the fence, there's a benefit to us as well, because it makes us aware of the risks to the visual state of the patient, and we can advise them on what to do, what to look for, and to be prepared if anything changes. And I think in this day and age of constraints of budget within the health service and everything, those simpler, straightforward treatments are so much more cost effective within the secondary sector. They're much cheaper. They're much more sort of time sensitive. They're quicker to perform, easier to perform, don't need specialist equipment, and don't necessarily need specialist super trained ophthalmologists to do the simple, straightforward work. And we avert major problems with that. And the other one is major potential litigation is averted as well. But with that, of course, comes the other side. It puts demands on the clinician. So this is what we're all about with all these lectures and these workshops and the great conference we've got coming next month. We need to have a full understanding of the ramifications of each of the lesions we see. And we need to understand what they're going to do, what they mean, what they're telling us, and what we should do with them. And I kick off with one of my favorite images tonight. As you may remember, this is one of my colleagues. We saw a very, very early tear in the retina there, associated with an area of retinal degeneration and white without pressure. And we were able to get that treated with a very simple, straightforward outpatient laser retinopexy carried out at that visit to the clinic while he was there. All done, all dusted within an hour. And the cost to the NHS, very, very much a fraction of what it would have been if more complicated surgery was needed. And also the cost to the patient in all respects, absolutely minimal. So this is what ultra wide field imaging allows us to do with these peripheral changes that we see here, and especially when it comes to things like retinal flap tears that could result in more serious retinal detachments. So we're going to go through a series of things tonight, again, as we have done in the past. Going to start with atrophic retinal holes. Now, anybody looking at ultra wide field imaging, especially if they're fairly new to it, will be somewhat concerned about the number of holes they see in the peripheral retina. And there's very much an association between holes and the fear that the retina is going to detach within seconds. And, if I don't do something with this hole, I could end up in all sorts of serious problem. Well, the simple fact of the matter is atrophic retinal holes, in the vast majority of cases, are not a problem. And I won't say they can be ignored, but the next best thing, they can be monitored without any further action necessary. And I think that's a really important message to take home, is that holes are not the sort of bogies that we've led them to be over the years. And the important thing about an atrophic retinal hole, yes, it's a break in the retina, but it is not associated with vitreoretinal traction. It's completely independent of anything going on within the vitreous and the retinal surface. So atrophic holes have nothing to do with vitreoretinal traction. They're full thickness retina breaks and they're in the periphery. Obviously, we know what a macular hole looks like. Well, a peripheral atrophic hole looks exactly the same in many ways, but it's in that peripheral retina. And again, 5% of the general population have atrophic holes. So where we've said in the past that with lattice degeneration, 10%, so in every 10 patients you see, one of them is going to have lattice. Well, in every 20 patients that you see, one of them is going to have a hole, or at least one hole. So these are not uncommon findings. And there is a result of atrophic changes thinning within the sensory retina. And then, as I say, they're not induced by vitreous adhesion. Often, as we've said in the past, they're found in association with lattice degeneration because it's thinned, degenerated retina. And almost half the people with lattice degeneration will have atrophic holes within that lattice degeneration as well. And it's atrophy of the sensory retina, hence atrophic retinal hole. They're round or oval in shape, but they can vary massively in size. Sometimes you see tiny, tiny little ones that you would need a lot of magnification to see. Other times they can be 2, 3, 4 disc diameters big. And so, sometimes the bigger holes panic you a little bit more, but the same ruling follows any atrophic hole. If it's big, then it doesn't matter in that it's not being pulled on by the vitreous. But quite simply, if you take a plastic bag and you pull it and pull it and pull it, you will thin that plastic of that plastic bag until little holes start appearing in that material. And that's essentially what's happening with an atrophic hole. So um, normally they occur sort of around atrophic chorioretinopathies, so old inflammations within the retina, and again the retina begins to die away, and so you'll see that there. And as the blood supply to the peripheral retina is shut down, then that retinal tissue subsequently dies, it thins, and you start to see holes appearing in it. But as I say, as we move on from this slide, atrophic holes do not involve traction of the vitreous and the underlying sensory retina. Now, they may be surrounded by pigmentation. This is a good sign because it means they're chronic, and so they're likely to be stable. They lack any form of sort of connection to the vitreous. So we talk about vitreous tufts or tags, that sort of abnormal adhesions of the vitreous to the retina. They don't have any of that associated with atrophic holes. You may see some subretinal fluid around them, and that may be sectoral, just sort of a quarter of the area around, or it may go completely the whole way round the hole. And okay, in a small minority of cases, that subretinal fluid will not stay localized around the edge of the hole. It will spread and it can result in a retinal detachment. But invariably, those sorts of atrophic holes that have that sort of thing going on will have symptoms associated with it as well. And those symptoms will affect your judgment as to what to do with that patient. But it's rare. So what sort of things cause atrophic holes? Well, retinal vascular disease, as we said, as the periphery loses its blood supply, loses its ability to function, then we see atrophy of the retinal surface. The retina thins, you get cell loss there, and then the retina, because it's thinned, begins to create holes in it. High myopia, we're going to touch on myopia again this evening. Why wouldn't we, with tears and detachments? So high myopia, the elongated globe stretches the retina, causes the retina to thin, and therefore you're at higher risk of hole formation. Think of the pulling on the plastic bag and the holes opening up on that. Lattice degeneration. Well, we know that lattice degeneration has holes in there, and pretty much 50% of people with lattice are going to have holes in there. So we know we've got to look for holes in lattice. Trauma, a sudden blow to the head, a sudden knock to the head sideways. So people who are carrying out sports, boxing, contact sports, boxing, rugby, these sorts of things, quite often those inertial bangs to the head can cause a sudden jolt of thinned retina, which could cause a hole to open up then. Age-related retinal thinning. I'm afraid as we get older, the retina thins as we get older, and therefore there's more chance of holes developing as people get older. So you may start seeing holes in long-standing patients, and you won't find them in the notes from 20 years before or something like that. Don't panic. It may be a normal aging process. So vitreous degeneration, whilst not directly tractional, you can get chemical changes in the vitreous, and that can cause changes to retinal tissue, cause it to break down, and again the retina thins and holes form again there. Exposure to ultraviolet and blue light also. And then you remember back to earlier lectures when we talked about the importance of retinal pigment epithelium. If that becomes damaged, that thins and we get retinal atrophy and we get holes appearing. And oxidative stress is obviously bound up with all of the metabolic function within the retinal pigment epithelium as well. Nutritional deficiencies, again, lack of essential nutrients impairs the photoreceptor function, and we get the same problem with cell death and therefore retinal thinning and holes again. Some people are genetically predisposed to it. Systemic connective tissue disorders can cause a problem as well. And previous inflammations can cause damage to the retina. But you'll see with all of these effects, what we're seeing is death within the peripheral retina. That death results in thinning of the retina, and therefore it's more prone to holes opening up in it. So we need to take all of those into account as we go. So what are the potential complications of these holes? Well, relatively low risk of the hole developing into a retinal detachment. So that's good news, but we shouldn't just take that and say, it's an atrophic hole, don't worry about it. We always need to consider there is a possibility, albeit very low, and therefore we should treat it accordingly. So you may get slight separation of the retinal layers caused by fluid seeping through. Now, the thing we're going to go on and see later on is that with PVD, the vitreous liquefies. So when you've got liquid, it can get through holes, however small. When you've got a gel, it can't get through holes. And that's the whole point here. The vitreous, in the main, stays in a gel-like form. So with an atrophic hole, you've got gelatinous vitreous next to it, so it can't seep through the hole. And that's a really important thing to bear in mind. So really, with asymptomatic atrophic holes, they are stable and just regular observation is recommended. So the patient needs to be aware that they've got some holes. They need to be told that these are perfectly normal. They occur in 20% of the population. They're really quite common there. So that's important. Sorry, 5% of the population, so 1 in 20. So they're really quite common. So if they're going out for a drink in the evening with friends and there's 20 of them there, one of them's going to have holes in their retina. So this is the sort of analogy we can use to put people at their rest. And we've seen sort of within various research papers and research that's been carried out that this is a justified approach because the risk of progression to clinically significant detachment is about 1% in eyes that don't have any other risk factors. So you certainly should not be referring every patient with an atrophic hole because 99% of them do not need to be referred. And maybe that 1% don't need to be referred initially either. So it would be a gross over referral rate. If the hole is symptomatic and there are signs of fluid accumulation around it, or you've got other things like the patient has a history of retinal detachment, then yes, this is not a sort of eye without any other risk factor. So we really need to be looking at that and potentially referring patients like that. So, but you'll see there in red at the bottom, careful surveillance remains the standard of care with atrophic holes. Now, as I said, you can get fluid around these subclinical detachments you get. And these are basically bits where you've got fluid seeping under the edge of the retina, but it's really not going anywhere. It's staying localized. So you get that little cuff of fluid around the edge of the retina. They're discrete. They don't normally lead to larger detachments. So if you see a hole with a bit of a cuff around it and a bit of fluid trapped underneath it, this subclinical detachment is actually not uncommon at all. So you can see here, there's some big holes here, and you've got a localized subclinical detachment around there, but then it's pigmented, it's held in place. There's not a problem with that. So we can leave those. They wouldn't warrant referral. However, when you look at an image like this, you can be confident to say, well, it's a subclinical detachment, it's probably okay. But look at the whole retina. You can see here you've got a very large area of sclerosed vessels, and you may well have a collapsed schisis here, or you may actually just have a whole area of degenerated, thinned retina. Now, personally, if I didn't refer that, I wouldn't sleep that night. I would refer that because I would want a vitreoretinal surgeon to be happy themselves that that was stable and that I could continue to monitor it. And this is what I was saying earlier about how generally atrophic holes are okay, but you need to be happy in your own right with what you're looking at. You will see partial thickness holes as well. These can look like holes. They're less easy to see, but very common in areas of retinal degeneration. You can see with the OCT, and OCT, if you can get an OCT on these peripheral changes, it's fantastic because it gives you an excellent solution. You can see here, this is only a partial hole here, and the retina remains intact. There's no way fluid is going to get through there. So these partial holes, partial thickness holes, you're just going to monitor those as a sort of variant of the norm. There's no problem with that at all. But I often refer back to these American Academy of Ophthalmologists PPPs, or preferred practice pattern guidelines. And basically they're saying that, especially in areas of lattice degeneration with minimum subretinal fluid without progression, we monitor. They do not require treatment. So this is one of the many guidelines that come out on these sorts of things. So again, it reinforces this whole thing that we're monitoring with these. So considerations when you're looking at atrophic holes, generally they're chronic. Therefore, they're usually long-standing. You see a hole, it's likely to be long-standing. It's occurred as a result of retinal degeneration. So probably the more relevant questions here is what's causing the retinal degeneration? Have we got vascular defects? Maybe, forget the hole, the more important thing is a vascular workup to see what's happening with the patient generally. Are there genetic defects they didn't know about? Maybe the more important thing is genetic testing and counselling. And lifestyle problems. Well, maybe the dietary advice is more important, or stop smoking advice is more important. But look at the whole, look at the reasons behind the whole, and look at the ramifications of those reasons and whether we need to be giving advice elsewhere. Does the whole have evidence of a fluid cuff? If there is fluid seeping underneath, then, as with that other slide I showed you, you may refer for potential treatment, but you may just monitor. Look at what you're seeing, look at the overall state of the retina and decide from there. Are the hole margins pigmented? Well, if they are pigmented, the hole has been there a long while. It's chronic, it's long-standing, it's stable. Note it in the notes, stable, long-standing hole, pigment around edge of hole confirms. And that sort of noting in your notes covers you completely. What's the size of the hole? Does it make a difference? You could argue larger holes are more relevant, but it's more about the surrounding retina. If it is degenerated roundabout, you may want to refer, or you may want to consider referral. Is there a history of other factors, a detachment in the fellow eye? If there is history like that, then again, maybe the referral option comes up the agenda quite rapidly. What's the myopic state of the patient? Are they a myope? Are they high myope? We know that they are more at risk of developing full-blown detachment. So look at the evidence, look at what you've got, look at the overall evidence presented by the patient, and then you can make decisions on from there. So let's look at a couple of instances here. Here's an eye with some holes that have been lasered in the past. You can see the beautiful retinopexy there, but we've got another untreated hole over here. Now, is that a new hole? Why didn't they treat it in the first place? Well, if we look at the surface here, we can see the retinopexies are probably fairly new because there's still pale areas and the scarring hasn't formed up fully. But when we go looking deeper in the retina, that ophthalmologist must be very proud of that retinopexy because it's beautifully neat. But look at the hole over here. It's small, the retina around it isn't degenerated, and you've got a large cuff of pigment around it. So this is a classic, stable, long-standing hole. So they will have looked at that in clinic and they will have said, don't even need to go near that one. That is old and stable. So again, when you're looking at holes like that, you can leave them well alone. And here's another one here. And again, if you look at the surface of the retina, you can see bits and pieces going on here. But when you look here, you can see it's pigmented, it's stable. A few other little indicators here to look for. Remember when we started off these lectures, we said, look at the whole eye. So there's your vortex veins. See a double vortex vein up there? They don't always come singly. You sometimes get doubles. So you're way out in the periphery here. And note also, you've got a couple of nevi here as well. All of these things tell you a bit about the state of the eye. Overall, this eye is looking healthy. You've got a pigmented hole there. Leave it well alone. You're not going to refer that. When we look at the OCT, we see there's no obvious vitreoretinal traction. There's no obvious cuff around the hole. So no further action there at all. Here's one of my favorites. Lots of atrophic holes associated within the lattice. You can see the lattice clearly all the way around. You can see tiny little cuff of fluid around each of these, and you can see the different variations in hole size. But again, this is common in lattice, and even in of itself, it doesn't need any further action. And again, here's another hole, and again, a beautiful, this is one of the early put together images in lattice. You can see that little fluid cuff, that localized detachment there, but absolutely sealed. So again, these sorts of holes, we're not going to do anything with. And we have another hole there looking beautifully formed. And again, if we look at the OCT, we see the full thickness hole, but no real cuff, maybe a tiny spot of fluid under there, but you can see a bit of fluid there. These localized detachments around these holes are quite acceptable, and you need to do nothing with them if the patient is asymptomatic. And here's another hole looking a little bit more obvious, but again, if we look at the surface, still make it out, but when we go down to the red channel there, the deeper channel, we see that very heavily pigmented cuff around there. That is absolutely stable. It's chronic, it's long-standing, it doesn't need anything doing to it. And if you want more evidence there, you can see the underlying choroidal vessels right around the edge. They're absolutely clear, so there can't be any fluid underneath there at all. So you've got all the evidence you need there to hold that patient and monitor that patient. And you sometimes get multiple holes. Here you see one again with fluid underneath it, but it's just a localized detachment there. Nothing to be done with those, even though they look pretty dynamic with all of those there, and you might think the retina's about to fall off. It's not. Those holes are stable. And here's another nice one. This looks like a nice big sort of hole here, but actually let's have a look and see what we've got. The hole has a pale cuff around it. The retinal vessels appear flat, so it all looks flat in that area. And then when we look at the red channel, we see this large area of pigment here, and we can see the choroidal vessels clearly, so there's no fluid there. But remember what I've said in the past here, when you look at these images, always magnify them up. And actually, when we magnify this image up, this pigment here is a little bit misleading, because actually, here's the hole, and there's an operculum. So this isn't an atrophic hole at all. This is an operculated hole, which rather nicely brings me to operculated retinal holes. So again, these are round or out of round oval holes, but this time you see a plug or a cap of retinal tissue associated with the vitreous gel. And it's in the locality of that hole. And now these holes are caused by traction on the retina by the vitreous humor as it liquefies with age. So as it liquefies, it begins to pull on the hole. So we've now got activity between the vitreous and the retina. With atrophic holes, the vitreous isn't involved at all. Now it is. So with the percolated holes, you will commonly see these with PVD. Obviously, things like trauma, sudden inertial, if you've got an abnormal adhesion to the retina, like a tuft or something like that, then that can tear on the retina and cause an operculated hole at that stage. So in most cases, no treatment is required because any vitreoretinal traction has ceased when that plug of retina is pulled out by the vitreous. So you would normally just note the findings and monitor. But some cases, if you have got vitreous fluid seeping under, which could increase the risk of detachment, then surgery can be performed. And if there are symptoms there, if the patient is experiencing flashing lights, or they've had a detachment in the other eye, i.e. the risk factors are higher, then we could probably consider that. And I put there, consider also the geographic location of the patient. What I mean by that is not where the tear is in, or the hole is in the eye. You guys are all down in London. You've probably got an eye unit very close to you. So that's good. But some of you may decide in a few years' time to give up the city life and you want to go for the quiet life, and you end up in the Outer Hebrides, where the nearest eye unit could be 250 miles away. That will change your thinking. If the patient does have holes in their retina, especially percolated holes, and you think there's fluid there, then maybe we should be looking to refer these patients for retinopexy treatment more commonly than we would if we can get them to an eye unit quickly. So, you may change your mind and move away from London. Think about the patient when you're making those decisions. So, as I say, operculated holes occur in focal areas of vitreoretinal abnormality. And this is where you begin to see the vitreous tufts, retinal tufts. So I've shown you tufts in the last lecture. And you also have areas of excessively strong vitreous attachment. Remember the vitreous base I showed you in the very first lecture? That's a really strong area of attachment of the vitreous to the retina. These can all pull on the retina and can pull chunks out of the retina. So we need to be looking for tufts. Here's a beautiful OCT, and you can see here this association of the tuft to the retina, and that's just going to get pulled out with PVD. So always be aware of tufts as well. And so just a few operculated holes to look at here. Again, here is an operculated hole, the very clear operculum. The relative size and location of the operculum to the hole tends to tell you a little bit about how long this hole has been there. Now, this one has actually had very, very fresh laser work carried out around it. That's yet to form up and scar. Here's my favorite one, which you will have seen in previous lectures, where we see the hole, we see the operculum well away from it and smaller, and we know therefore that that is stable. If we magnify it up, we get a much clearer view of it. You often get pigment around the edge, hyperplasia, which shows it's long standing. You see the pigmentation around the edge of the operculated hole there. Now that hole is sealed. We can see the vessels underneath clearly, so we know there's no fluid ingress there. So that's the important thing there. And then the OCT again beautifully will show you the pigmentation here. You get the negative image here as the pigment is so dense. You can see there's been some fluid ingress, but that pigment now blocks it from going any further. So it remains as a localized detachment at that point. Now here's another one that classically you will see here. There's this lovely area of white without pressure. There's the dark without pressure tide mark. So we know all that area out here, the retina has been pulled away in PVD, but we see within that the retinal hole with the cuff round it, the operculated hole, and there's our operculum there. So if you're seeing areas of white without pressure like this, look for an operculum, because quite often it will be there. And that shows you that all bets are off with that one. It's now looking quite okay. And you can see again the absolute evidence there is no fluid underneath that hole. So again, these are all just going to be monitored. Another nice one here with a bit of cuff underneath it. Here's another one that's been lasered. So what's happened here is the consultants probably looked at that. They've seen fluid leakage underneath. In this case, they've seen hemorrhaging here as well. So this has been a decision to laser this one to seal it. This could have been an eye that's had few pathology in the other eye. It could be a very high myope, something like that. And I bring you back to this image because it really is one of my favorite optical images of all time. This was an ultra wide OCT. There is the hole left in the retina, and there's the operculum still attached to the vitreous face. It's absolutely beautiful. You see how just that force has even pulled holes within the bit of retina that's pulled out of that hole as well. So the tractional force is quite huge on that. So it's quite amazing, really. But we see the fluid under here. Now, in this case, the consultant went on to do a retinopexy on that because they felt that fluid was risking there. So before we move on from holes, let's just summarize those quickly. Always, when you're looking at a hole, consider the overall risk of developing forward to detachment. With atrophic holes, very unlikely. But consider the condition of the retina. Do you have other degenerations there? Lattice, snail track, signs of PVD. These are all going to influence your decision making. Consider the prescription. Is this somebody who's +2 or is it somebody who's -10? That myopic shift will alter your thinking as well. Is the patient symptomatic or asymptomatic? Asymptomatic, probably we're talking monitoring the vast majority of the time there. Look for that underlying fluid, look for current activity, look for signs of aging and stability and chronicity. So that pigment around the margins. And if you're happy it's stable, you're monitoring these patients. So you monitor with suitable patient cautions, explaining to them what they've got and why you don't need to refer it. Um, Always tell them what to look for if there's a possibility of things happening further on from that. Uh, as I've done with a lot of these images here, annotate your images within the software of the system, because if you annotate those images, then anybody looking at that or trying to sort of mark your work can then have a look at what you've done and see, like this sort of thing here, they can see your thinking and your actions, and you've got absolute evidence you were doing the right thing there. So let's move on. The vitreous humor. So we've said about how the vitreous can react with the retina. So we've gone from it not doing that and atrophic holes to it doing that and tearing lumps out of the retina, atrophic holes. So the fluid, the humor, it's basically a gelatinous mass filling the space between the lens and the retina. Uh, it's fluid-like near the center, but it's gel-like around the edges where it's in contact with the retina. It has various points of attachment. They attach the vitreous at the nerve head, the ora serrata, the lens capsule, on retinal vessels and the macula. So it's firmly attached to retinal vessels in the periphery. Remember, the peripheral retina is much, much thinner than the central retina, so much more prone to tearing. So as the eye ages, the collagen fibrils break down. This leads to liquefaction of the gel, and you get fluid-filled pockets within the vitreous. Uh, and this is the important thing, because the very large tractional forces that arise between the vitreous and the retina are what cause the potential risk to the retina, the potential for tearing. And now, because you've got liquid there, if you tear a hole, you've got the opportunity for liquid to leak through the hole. If you've got gel there, the chances of that leaking through the hole are very, very low, if at all. So you begin to see this sort of pulling away of the vitreous here, still firmly attached in some places where it's going to pull and could tear the retina. And if it tears the retina, this is where we see the classic flap or horseshoe retinal tear. And this is ripped the whole of the retina out. So it's a full thickness tear of the retina, but it still remains attached at the anterior point of this break, of this tear. So as the PVD occurs, it pulls on the retina, it pulls it up, pulls it up, pulls it up, and rips it out. But the apex of that retina stays attached. So the more the vitreous pulls away, the more it pulls there. So if you pull on the back of your hand and tear it, it'll just keep tearing, 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 which will be very painful. But that's the sort of thing that happens. So these flap tears are most often found between the aura and the equator. That's because the retina is thinner there. And this traction may have been going on for months, sometimes years, before it suddenly gives way and you get this tear. So you'll often see pigment clumping at the base of the tear or the flap. But remember that vitreous traction remains at the apex of the flap, so chances of detachment are significant. And this is the classic sort of sign, sort of image you see here. So there's that flap tear there being pulled up. But remember, a tear is not a detachment. A tear is simply that, it's an opening in the retina. But what that opening allows is fluid to seep under the retina. And it's that fluid seeping under the retina that causes the detachment. So here we are, you see, there's the tear, tearing that hole open. And because the vitreous has liquefied, you've got syneresis here. This fluid is now free to drain through that hole and into the gap between the vitreous and the retina. And that's when it begins to push its way through the retina and pull the retina off. So this is the sort of thing that you see here. So then you get the retinal detachment occurring here. So your vitreous is collapsing away. A lot of liquid there. The vitreous tears the hole in the retina, the flap tear, and then the liquid piles through and pulls the retina off. So a tear is a tear. It is not a detachment. It facilitates the detachment. So these are full thickness breaks of the neurosensory retina. Often, again, you get a pale collar around the break where you get a localized detachment again. But the important thing is, if these are symptomatic, anything up to 90% of them will progress to a detachment. So we're going to refer all of these flap tears. Even if there's no overt sign of a detachment, we're going to refer them at this stage. Remember that very first image I showed you of my colleague? There was a flap tear. It hadn't developed into a full-blown detachment, but it was very high possibility of it doing so. Treat it at that stage, do a retinopexy at that stage, preserve the retina and take away the chances of detachment. So with asymptomatic, I think this is an old statistic here personally. They say 5% of these will progress to a retinal detachment. I actually think it's much higher than that. The only time we know that it's gone to a retinal detachment is when the patient comes in to see you 6 months after their last sight test, when you told them everything was normal, and they say, oh, I've had a retinal detachment. And that's probably because there was a tear, but if you weren't using ultra wide field imaging, you didn't see it. So again, patients who are highly myopic have an increased incidence of retinal detachment as a result of these tears. So again, we would consider very strongly treating these people. So what are the risk factors for development of a horseshoe tear? Well, lattice degeneration. Remember that statistic, 10% of the general population have lattice degeneration, but a third of patients with retinal detachments and no other compounding factors have got lattice degeneration. So very, very high increased chance of detachment in people with lattice degeneration. People with myopia have longer eyeballs, stretch, thin the retina, making it much more prone to tears. Eye trauma, so people who are carrying out sort of concussive type or percussive type sports and hobbies. Don't forget the classic bungee jumping. For some reason, people still go bungee jumping. That bit where they drop and bounce back up again, the massive amount of tractional force on the vitreous and the retina in these people, it's been so well documented. And of course, the other one that I keep seeing everywhere now, so many reports recently, paddle. Why people play paddle? They obviously just don't value their eyesight. Prior eye surgery, cataract treatment, weakens the retina in a lot of people, which can lead to these types of tears. So I'm not going to go through all these statistics in great detail here, but a significant number of people do go on to get retinal detachments within 2.5 years of cataract surgery. And again, myopes who've had cataract surgery, a much, much greater chance of detachment there. Previous history of retinal breaks, again, 1 in 8 people with retinal detachment develop subsequent detachments in the contralateral eye. It's quite a high number. Family history and aging again. Aging is one of those things. I have to say aging is good because the alternative is really not very nice at all. People with diabetic retinopathy, the same old sort of culprits really, inflammatory conditions, malignancy, congenital eye diseases, genetic disorders, ethnicity, all these sort of side factors that we need to know about our patient can tell us an awful lot about what's going on there. So let's just look at the factors that influence the rise of retinal detachment in myopes. So with myopes, you see much earlier onset of vitreous liquefaction. So you've got much more liquid between the vitreous and that retina at a much earlier age. So be aware that all your myopes have probably got liquid between the vitreous and the retina at an early age. So if they've got thinned retina, there's likely to be fluid there much earlier on than you would expect in other people. The greater axial elongation leads to that thinning and therefore more pathology there. And these statistics I thought quite frightened me in one sense, but the eye disease control study group who carried out a very large bit of research here, they showed that anybody with myopes of -1 to -3 had a 4-fold increase of retinal detachment. -3, greater than -3 up to -6, a 10-fold increase in retinal detachment over an emmetrope. And high myopes, -6 or over, a 20-fold increase in retinal detachment. This is why it's so vital to know what's going on in the periphery of these myopes. It really is. So let's just look at some detachments here. So here is your horseshoe tear. Here's the gap that's been created, and we see the retina detached here. Why is the retina detached there? Because the fluid under gravity has poured through that hole and piled down the retina here. So this is important to know. It's important to understand because this patient might have to wait 24 hours before they're seen in a clinic. We hope not, but they might have to. What you tell this patient at this stage is so important. So we're looking at posturing in patients. We need to make sure that if they are having to wait, their head is in the right position so that gravity favors what they do. You get this person laying the wrong way round and you're going to rip their macula off. So again, look at what the image is telling you in relevance to what you're going to give advice to the patient. And we see the surface of the retina here with the green channel. Immediately when we look at the red channel, though, you can see what I mean here about loss of clarity due to fluid. We've got beautiful view of the choroidal vessels here. We've got complete loss of those choroidal vessels here due to the fluid that's between the retinal surface and the underlying layers. So again, this helps you to understand the extent of the detachment that's going on, and we can see that's very clearly a detachment there. Eye steering gives you more information because you can now see the full extent of that retinal hole, that flap tear, sorry, not hole, that flap tear there, and the retina coming off. So don't forget eye steering, even though you may have an obvious detachment there. An assortment of other detachments here. Here we see there's a flap tear, there's the flap, there's the tear, there's another tear out here. They look beautiful. I have to say, sadly, retinal detachments can look really beautiful on ultra wide field. But you must send these images. If you've got a patient with a retinal detachment, not only do we need to let the clinic know that the patient's coming in, you need to send these images either directly to the clinic or via the patient's media, their iPhone, other phones exist, or their iPad or something like that. So they take it with them so the consultant can see immediately. But if you can get this sent ahead, that is so much better because the consultant knows what's coming in. There's a glorious one. Macular off, not good at all. You know these are detachments. These are obvious ones. So they're always nice here. But again, if we look at this one here, we know there's a detachment going on here. We look at the surface, we can see the buckling of the surface of the retina here. But then when we look at that red channel, now you can see the extent of this detachment going all the way around here. So this is pretty much a complete inferior detachment here, encroaching upon the macula there. And you see how pale it is round here. So again, we're seeing that fluid moving forward. Posturing is so important in a patient like this, as is speed of getting them seen. Now, giant retinal breaks and retinal dialysis, these are the real sort of beauties from our point of view of looking at them. They're not so beautiful for the patient. These are major detachments within the retina, and they're going to extend at least 3 clock hours worth around the retina. Sometimes they'll take half the retina off completely. And retinal dialysis is an even more severe type of detachment. And I want to draw your attention to this for almost a reason apart from the detachment, because most of these major detachments like this, especially with retinal dialysis, are associated with young patients. There tends to be a greater number of males than females, and they are commonly associated with ocular trauma. Now, I'm afraid it's the old sort of pub scenario at 11 o'clock at night. The sort of punch up outside still causes things like that. But importantly, nowadays, I want to get you to remember if you see somebody coming in, and I have to say, especially if it's a female patient who is showing signs of retinal dialysis, you need to treat these patients very carefully because not only is their treatment very, very complex to save the eye and get the retina reattached, but the cause of that dialysis is very important. And you should have at the front of your mind with a retinal dialysis patient abuse. And I'm sorry to mention it, but think abuse with these patients because an abusive relationship can often be physical and often can result in this sort of thing. Now, often these patients will not go to hospital because they know if they go to hospital, they're probably going to be found out. Somebody's going to think about that. So they often look for alternative places to go. They won't go to the doctor because the doctor's going to send them to the hospital, but they will come to you because they don't think that you'll send them to the hospital. Luckily, their lack of knowledge of what we do is often useful from that point of view. So you may be confronted with these retinal dialysis patients, and if you are, then you must think abuse and look at that very carefully. Think of your referral pattern, but think of that patient and whether you need to be doing something further with them as well. So I just point that out because dialysis can mean that, and it can be missed as a result. So do think on that. Here we see the sort of dialysis patient you're going to see, looking pretty phenomenal there. We know it's a detachment, but how are we going to treat that detachment? So these are all retinal dialysis patients here. Here's a giant tear here. You can see this tear extending at least 2 to 3 clock positions there. Another group of people you've got to look for are the tumours. This is a very classic tumour here, and the head of that tumour is pushing up, pushing up, pushing up, and it's just pulling the retina off around it. So actually there's the head of the tumour there, but the whole of the retina around here has been taken off as well. As you can see, this loss of definition down here. So it's pulling the retina as it extends. So again, bear in mind, tumours can cause detachments. So just a couple to go through here. These are images I've shown you before, but remember, something's happening in the periphery in this patient. We eye steer them. There's our retinal tear, and there's the classic fluid coming down. But look at other parts of the retina as well to make sure if you've got any other pathology here. So we see this area is blurring out as well as this area here. So we've actually got a multiple detachment going on here. So when you see a very obvious detachment, don't forget to look for other areas as well. This is similar to one we saw earlier. The patient is telling me he thinks his vision's got bad. This is his so-called good eye, but when we look in his other eye, this eye had a pseudomacular hole, so his vision was poor. But actually, it's this eye that's causing his problem, and we can see the area of concern here. When we look at that with eye steering, you can see the retina here. The blood vessels are very distorted. They're changing color as they lift up over that detached area of retina. There is the flap. It's very important to find this flap in the retina if you can, because when the patient is going to be treated, we're not just looking to put the retina back on, we're looking to seal that area as well. So often treatment is delayed if they can't find the flap. So the reason this is like this is that the patient actually phoned me and said the hospital want to treat me, but they can't find the hole in the retina. So I actually had to send them this image with that in there. I don't know why they couldn't find the hole because it's pretty obvious, but that's what we had to do there. And then we look at the red channel. You can see how we've lost that definition of the blood vessels here. So this is a large area here of detachment, which is then confirmed when we look at the OCT. So again, if you can get an OCT on these areas, it so helps your diagnostic abilities. And this is another bit of lattice degeneration here, one of my classic boggy spots, as I used to call them. Boggy spots, you get vitreous traction, pulling on the retina tears, and the fluid caused by syneresis piles through that hole, and it begins to pull the retina off. This one, you've only got localized detachment at the moment because it's in the lower half. Gravity is your friend at this point in time. So here's a table that I put. I'm not going to go through the table, but because you can access the lecture later, this is a very useful little table to download just to give you a little sort of aid memoir as to what you're looking at on the retina and what sort of treatment option you're going to go to. This is another of these American Academy of Ophthalmology preferred practice patterns again. Very, very useful to help you with this. The only thing they don't tell you here is the asymptomatic dialysis. They don't put the bit in about abuse, but please don't forget about abuse with patients. Lots of references for you this time, so if you want to go back and look at some of the other bits and pieces, please do. And now for a bit of fun at the end here. Please do, we've got a couple of moments left. Please, if you want to, download this QR code. And this is quite I mean, it's not one I would sort of say you've got to slavishly take to heart, but this is what they call a predictor. A retinal tear. What's the chance of a retinal tear developing into a retinal detachment? And you can see, if you do this, you'll find the retinal tear risk factor checklist. So under new flashes or many floaters, I'm going to say this patient's got floaters and new flashes. Are they nearsighted? Not sure or no. They've had no tears previously. Recent eye surgery? No. Family of history of retinal detachment? Yes, their mother had a detachment. And it brings you up this lovely little diagram here. And you can see there are several risk factors. Recommendation: book a dilated retinal exam soon. Ask what symptoms should trigger same-day care. So it's a nice one for patients, and it's quite a useful one to give patients, especially high myopes. But actually, it's quite useful for you to use in practice as well when you've got a patient giving you symptoms, because you can say, well, here's one of the tools I use here. And you'll see from what you've told me here, it's telling me that you've actually got a low risk, or you've got a high risk, or I'm sending you to the hospital. So don't slavishly use it, but it's quite a nice little bit of kit. You pick up all these nice, fun little things on the web nowadays. So you've got that there as well. So we come to the end of the 5th lecture, and if you have any questions or anything, I'm sure we can go to some questions if you've got some there, and then please bear in mind we've got the conference coming up. We're going to have a great day at that conference, and then we're going to move into some workshops, which I'll explain a little bit more about at the conference as well. We've got some great stuff coming up for you.
Thank you so much. That was just amazing as always. And it's so useful to have these images, isn't it? It just sort of picture just says so much, doesn't it?
Oh, it does. I
Um,
mean, I think it helps.
yeah.
So if there's any questions out there, please do fire them in.
So nothing in the chat. I invite our participants, if you want to, please do take yourselves off mute and ask questions if you have any questions. We've had some thank yous in the
Oh,
chat.
thank you. Yeah, that's nice. Thank you. I always love the thank yous. Thank you very much for that. But
Hi. If I can ask a question, Simon.
yep.
I had a patient recently who mentioned that his floaters were becoming more obvious and larger, not necessarily new. So I decided to dilate him. And I could see what I was suspicious. There was a scarred area in the periphery of the right eye. And I could, on slit lamp examination, I could see what I thought was a tiny round operculum. So it was that kind of color, that sort of like opaque-ish, quite circular, was forwards in the vitreous. You could see it wasn't like a traditional floater. And I was suspicious, and it was just in that region where this scarred area was. I asked him about the scarring. Has he had any treatments, anything, blah, blah. He said nothing that he's aware of. And I then got them to eye-stay on Optimap because I couldn't actually see the whole of this scarred lesion, wondering, is this an operculum? Has it come from this region or what? So one of my colleagues actually eye-stayed. I then managed to see the whole of the scarred area, but couldn't see an actual hole from where that operculum could have come from. But it looked classically like, to me, it looked like an operculum. And so I was in until we did the eye steering, and I could not see where it had come from. My question is that operculum ever likely to move away from an area over time, or will it normally just stay sort of within that region?
Normally it will stay fairly close. I showed you the image earlier on, didn't I? Of an operculated hole, and you'll see in that image there,
Yeah.
Where are we? There, so you can see in this image here, the
Mm-hmm.
operculum has moved away from the hole, but it won't move a long way from the hole. And I think it depends also, if it's superior, obviously under gravity, it can move further than it would in the inferior part of the retina. But again, with these sorts of patients, if you've got an operculum there, then normally it's pretty safe. If you're not seeing flashing lights and the floaters are long standing, um, it's liable to be a stable condition.
Okay.
Uh, As to whether you refer these sorts of patients or not, as I say, I probably would not refer a patient like that, because with eye steering, I'm going to get pretty much out to the periphery there. And if I'm not seeing an obvious operculated hole, then my feeling would be that there's nothing wrong there. Again, this is where your red channel comes in so importantly as well, because if you can still see all the choroidal vessels, you know you're not dealing with any fluid underneath the retina there. So I would just make very good notes and annotations on the image and good notes in the patient record. But if you're still unsure at that stage, then by all means refer. And within that referral, point out that whilst you don't think there's a problem, these are the reasons why you feel your referral is justified. And an ophthalmologist will be happy with that 99 times out of 100, because they can see you've got a justification for that referral. And I always put on referrals like that. If you confirm there is nothing wrong, as I suspect, I will be happy to monitor this patient. And you put something like that, you normally get a letter back saying you're absolutely right in your thinking. I'm very happy for you to continue to monitor that patient.
But the other thing as well, is Simon as well, I forgot to mention, is that it was the left eye the patient was complaining about, and this was actually in the right eye. So
well,
he was
that makes
confused.
it even,
I did ask.
that normally makes it even less likely that it's going to be anything serious, but it also
Okay.
confirms the beauty of why we use ultra wide field retinal imaging.
Okay. No, good.
I rest my case.
Yeah, that's great. Thank you very much. Thank you.
Okay. Somebody's asking a question about posturing.
Yes.
So posturing is not you standing there with your hand on the hip looking pretty special in your clinic. Posturing is about where you position the patient's head. So obviously, if you've got a hole that's got fluid leaking through it, it's going to rip the retina off. So if that's in the superior part of the retina, then that liquid is going to fall under gravity downwards. So you want that patient, the best way to put that patient is get them to stand on their head. Now, that's not going to be feasible, obviously, but you've got to put that hole in a position where the fluid is going to go in the opposite direction to where the macula is. Okay, so think about where the detachment is, and you're looking to prevent fluid moving towards the macula. So when we look at one like this, the fluid's here. If you turn the patient on their side such that that fluid is going to travel towards the macula, you're just going to push the fluid through to the macula. So you want to turn them the other way so that the fluid is going to move towards the periphery. That way, so they're sat here like this until they get to see the consultant, or they're sat here like this until they get to see the consultant, so that the fluid does not encroach towards the macula. Okay. And it's also worth putting in the referral and in your patient notes, patient instructed to posture in such and such a way to preserve macular integrity. You put something in like that, then if the macula ever comes off, you've got evidence that you showed them what to do and you did everything you could to preserve their macula until they got treated. Okay.
Brilliant, thank you. There was another question, if that's okay. It's about patients who've had a vitrectomy. Can they still complain of floaters in that eye?
Patients always complain. Yes, they can, and there could be, obviously, vitrectomy. You've removed the vitreous and hopefully the contents there, and you've replaced it, or it replaces with aqueous normally over time. you will still get debris in there, and you can still get debris coming off the surface of the retina. They will still have floaters. Um, and so, bear in mind that that is a possibility. Okay.
Yeah.
And uh, once a person has had uncomplicated PVD, does the risk of retinal detachment reduce? Absolutely, it does. Once you remove that sort of tension between the vitreous and the retina, once you take that pulling away, the retina will settle down, uh, and therefore it will go back to normality. That being said, of course, the vitreous doesn't, it's an annoyance in that it is stuck to the retina and can pull on the retina. But once it's pulled away, you've lost the structural integrity on the surface of the retina that holds it in place. So patients can be more prone to detachments, normally due to trauma rather than anything else. So if you've got a -10 myope who's got naturally thinned retinas in the periphery, and they slip over on a sort of pavement of ice and smash their head on the floor, yes, they might sort of get a sort of hematoma on the brain at the same time. But provided they don't get something nasty like that, there's every chance that that sort of that injury, that sudden jolt, or even a whiplash injury in a car, that sudden jolt like that could conceivably tear a retina anyway. But because you haven't got the pulling of the vitreous on it, it's less likely, but it's not out of the question at all. But the highest danger time is when that vitreous is actively pulling on that thin retina.
Mm. Yeah. Um, one of the registrants has asked, what is the likelihood of RD after vitrectomy?
Uh, Statistically, I can't tell you the exact answer to that. Obviously, the whole idea of performing vitrectomy is to tease the vitreous off the retina to take away the vitreoretinal traction that is there and to prevent scarring as well. And obviously, then to sort of replace that. Uh, but the vitrectomy is it depends really in a sense what reason the vitrectomy is being performed, to be honest.
Mm.
But the likelihood of retinal detachment is much lower after a vitrectomy. This is one of the reasons it's performed. It's one of the reasons vitrectomy is performed at the time of many retinal detachments as well, because subsequent problems don't arise. So I'm going to give a very sort of almost political answer here and say it's less,
Yeah. Yeah.
significantly less.
Yeah.
But again, these are all, you can never have absolutes in anything medical. So there are still possibilities of it, and there's still a chance of inflammation soon after vitrectomy. So the risks are still there, but over time it should settle. And but from what I've just said here about once you've had vitrectomy, you've effectively removed the vitreous from the retina. So you've still got, I refer my learned friend to the answer I gave just now.
Absolutely, absolutely. And you can't forget that when patients say that they've had a vitrectomy or they may know that word, they may not know whether they've also had at the same time an ERM peel or an ILM peel at the same time. So that does add layers of complication to
That's correct. Yes, that's true.
the reasoning. Thank you so much. I don't know if there's any more questions. If you have any more questions, I'll give you a couple of moments just to put that in your chat, or please feel free to take yourself off mute. Um, it has been most informative and absolutely necessary. I think this conversation and this subject matter is absolutely a worry for most practitioners all the
Yeah.
time.
I
Yes,
think if you can see that periphery, it's so much better. Even if you
yes.
see stuff, you can deal with stuff. I In another lecture, I have a classic scenario where you see a patient, a 23-year-old who's just come in for a computer exam. She's got no symptoms, she's got nothing at all. So you send her away, so everything's fine, and then she comes back 4 weeks later saying, "I've just had surgery for retinal detachment," and she's just come in to ask you for a copy of her records so that she can see what you wrote there.
Yeah.
And what's your first reaction?
Panic.
Because it was probably there at the time, but you didn't see it, And so, much as people worry about this, I think if you can see it, fine. But to be fair again, ultra wide field imaging is never just the absolute perfect answer to everything. And you've still got that role as a clinician. You are a highly skilled, competent clinician. If you're not sure, then you should always refer the patient. But it just allows you to have a very, very much better informed referral letter to your colleague who will thank you so much for that.
Yeah, absolutely. Can I slip in one more question that's come up in the chat? Can
Yeah.
you get pigment dust or tobacco dust, I guess, in the vitreous without a tear?
Uh, if you get something that you think is pigment dust without a tear, it's probably not tobacco dust. It's as simple as that.
Yes,
So ask yourself, what is tobacco dust?
yes.
And then re-ask the question once you've answered the question, what is tobacco dust? I'm not going to tell you what tobacco dust is, whoever asked that question. Go and find out what tobacco dust is, and then ask yourself, if that's tobacco dust, is it likely to come if there's not a tear? Because you will be able to answer your question yourself very
Yes.
fully. So
Yes.
there's a great bit of onward learning for you.
Thank you so much.
And then you can tell me the answer in June of the
Oh,
conference.
lovely. Yes. So just a quick reminder that our next session will be in person. It is being held on the 7th of June at London Bridge Hotel. Invites have gone round. If there is any information that you want on that session, then please do get in touch with the office and we will pass that information round to you. And otherwise, thank you very much for joining us this evening. The recording will be put onto our YouTube channel for your future learning. Thank you.
Thank you.